All right, good afternoon and welcome to our May information session. My name is JJ Knight and I am the Stakeholder Engagement Task Lead for the CMS Measures Management System contract supported by Battelle. Today, my MMS colleagues Meredith Eastman and Mujahid Khan are going to discuss several challenges often faced during measure testing and how to address them. If you would like to download today's slides, they are available on the CMS MMS Hub. My colleague Jake will pop a link into the chat. We also will post a recording of today's session on the MMS Hub in a few weeks. Next slide, please. As part of the Measures Management System stakeholder engagement task, CMS produces these information sessions throughout the year to educate about quality measurement topics and engage those interested in measure development and maintenance. In short, we host these sessions for you. I highly encourage you to submit questions throughout today's presentation using the Q&A feature near the bottom of your screen. We'll try to address as many as we can at the end of the presentation during our Q&A session. Now, I'm going to turn it over to Meredith Eastman to get us started. Meredith?
Thanks, JJ. And thanks everyone for joining today. Just to kind of level set, the purpose of today's talk is not to provide a comprehensive look at measure testing or even, a comprehensive look at the testing challenges that may come up. But what we do have prepared for today is an assortment of measure testing challenges that have been brought to light as part of our pre-rulemaking activities and other interactions we've had with measure developers in other contexts. So we have a selection of topics we'll cover today, and that includes understanding the differences between alpha and beta testing. We're going to talk about trade-offs between validity and feasibility. We'll talk about some newer terminology, which is patient/person or encounter level data, and how that differs from patient-reported data. We're going to talk about some repositories of existing data elements and the benefits of referencing those repositories. And we'll talk about some strategies for dealing with low frequency or rare events. And we're going to round out our discussion by talking about some promising practices for collaborating with testing sites. So that is a lot to cover in one session. So let's get started. Next slide, please. So before we dive into that list of challenges, I did want to just locate us in the measure lifecycle. So what you're seeing on the screen now is a diagram that's on the MMS Hub. And you can see the measure testing box highlighted in yellow there on the right. I'll point out here that measure testing has a bidirectional relationship with measure conceptualization, and that we have it situated prior to measure implementation. I'll also note that there's a bidirectional arrow connecting measure specification and measure testing in the diagram. Next slide, please. So that bidirectionality is a point worth reemphasizing. Today, we're specifically talking about measure testing during measure development, although testing can also occur in order to maintain a measure or to respecify a measure. And measure testing during development is absolutely iterative with specification. And that's, signified by this loop we have here on the slide. So you may assess the feasibility of an essential data element that's in your draft specifications, or you may make changes to your specifications that must then be tested. For example, you could test measured entity validity after removal of a low reliability data element. So this ongoing dialogue between testing and specification is important to understand conceptually, but there's also a more practical consideration, and that this back and forth between testing and specification can be time consuming. And it really needs to be accounted for when you're considering your timelines for measure development and testing. Next slide, please. So having situated ourselves in the measure lifecycle, we're going to move on to our first topic, which is alpha and beta testing. Next slide, please. So the terms alpha and beta are actually borrowed from other fields to describe versions of a product, such as software and development. So you'll often hear of a software product being in beta. It's a term we've borrowed from those types of fields. Other terms that you may have heard and that essentially mean the same thing are formative testing for alpha testing and field testing for beta testing. So you might wonder why we bother dividing the testing stage into these two parts. Well, these terms actually do represent real differences in measure testing activities. So broadly speaking, alpha testing tends to be more internal facing with the aim of improving the initial quality of the measure, whereas beta testing is more external facing and assesses the measure's practical application. There are other characteristics that vary between alpha and beta testing that we'll talk about in greater depth in the subsequent slides. But these characteristics include things like scope, timing, and purpose, sampling considerations, and the measure evaluation criteria that can be addressed by each type of testing. Before we move on to dig into those topics a little bit more, I just wanted to note that there are, again, some very practical reasons for differentiating between alpha and beta testing, because they actually often require different resources. So for example, you may rely on different staff with a different skill set for each testing step. You may be accessing different data sources, and there may be a different level of effort associated with each. So there's some important conceptual as well as practical differences that will come to light as we move through the next few slides. Next slide. So the next few slides, as I mentioned, outline some key characteristics of alpha testing on the left and beta testing on the right, so we can really get a sense of how these two components differ. So alpha testing is pretty limited in scope, meaning that you're kind of doing just enough testing to understand variation in the data to inform specifications. And usually alpha testing does start before detailed measure specifications are fully developed. So you may have a measure concept, and you're just starting to put together the data elements and data sources that will be needed to flesh out the measure. You can start to conduct this kind of analysis as part of empirical analysis that's conducted during the information gathering step of measure conceptualization. So it happens really early on. And again, alpha testing may occur concurrently with the development of technical specifications as part of that iterative process. Again, you can think of the purpose of alpha testing as really internal facing. It's really intended to influence the measure specification decisions. In contrast to that, on the right, we have beta testing. Beta testing is much larger in scope. You're aiming to engage enough sites that you can speak to generalizability of the measure. In terms of timing, beta testing is usually conducted after you have a solid set of technical specifications developed, though these would still be considered draft specifications. And measured testers are often encouraged to include all potential candidate data elements, even the ones that developers suspect may be unreliable or low frequency, so that those candidate data elements can be scientifically evaluated and tweaked, or even eliminated as the measure is finalized. We've also listed some of the key purposes of beta testing on the slide. So through beta testing, that's where you assess scientific acceptability. So that's reliability and validity, and the usability of the measure. You'll evaluate the measure's suitability for risk adjustment or stratification, and you'll expand upon previous importance and feasibility evaluations that you conducted during alpha testing. Next slide. So we kind of foreshadowed some sampling consideration when we talked about the different scope of alpha and beta testing. But to flesh out some more of these ideas, just a little bit more, alpha testing, again, is just comprehensive enough that all the data elements that are needed for the measure are included in the data set. You only need enough data to reach saturation, which refers to the condition where the universe of variation has been identified. So in terms of sampling techniques, alpha testing generally relies on a convenience sampling. So you're using the data that you have available or that you have easy access to. Sampling for beta testing is a different story because beta testing is addressing a different set of questions. In beta testing, you'll want to obtain a statistically adequate sample size so that you can assess reliability and validity. You want the sample to be as representative as possible so that your findings are generalizable. So this may mean that you include multiple sites with differing characteristics. For example, you may want to include a mix of urban and rural sites, depending on what characteristics matter for your particular measure. In beta testing, you're looking to use sampling techniques that are statistically appropriate for the tests you plan to run. So, for example, you might elect to use a probability sampling technique, such as simple random or cluster sampling. Next slide, please. So we've talked about how alpha and beta testing differ by scope, timing, and purpose. Over the next few slides, we'll talk about how these types of testing differ according to measure evaluation criteria. So we'll start here with importance. Again, we have alpha testing on the left and beta testing on the right. With alpha testing, you can obtain a sense of the overall volume or the frequency of the quality issue you're looking at. So you can answer the question, how big is the problem? Alpha testing can also affirm that there is indeed a gap in care that can be identified by the measure. And this information will provide support and justification for further investment in measure development. If during alpha testing you find that there isn't much of a meaningful quality gap, you may actually decide that this measure concept you're working on actually isn't appropriate for further measure development. That can be disappointing, but it's an important conclusion to consider as early on as possible in the measure lifecycle to avoid unnecessary expenditure and effort. On the other hand, beta testing will support importance evaluation through identification of performance thresholds, identification of disparities, and identification of variation in the outcome of interest. You can also identify statistically significant variability among comparison groups that you're interested in, which it would be an indication that there is indeed an opportunity for improvement. Beta testing can also help ensure that the measure is not quote unquote topped out. And when we say topped out, we mean that most groups that are being measured achieve similarly high performance levels that are approaching the measured maximum possible value. Next slide, please. Moving on to scientific acceptability. You can see we don't have much to say about scientific acceptability on the alpha testing side of the slide, but you may be able to assess face validity in alpha testing. And that is expert opinion that the measure appears to measure what it is supposed to measure at face value. With that said, questions of scientific acceptability are much more thoroughly addressed in beta testing. So you'll see on the right there, beta testing is when you do assess empirical validity and reliability. And as part of the validity assessment, beta testing also investigates threats to measure validity. Those could be things such as the impact of missing data or the appropriateness of exclusions. And lastly, beta testing also includes the testing of the adequacy of any risk adjustment model that you're proposing to use for the measure. Next slide, please. In contrast to that limited role we saw that alpha testing plays in scientific acceptability, alpha testing can contribute a lot to understanding measure feasibility. So for example, during measure testing, you'll assess if the required data for the measure can be collected and through what methods they can be collected. So maybe you'll look to see if a particular data element is included in the EHR, or if instead it's included in an ancillary administrative data set that you don't have access to. Alpha testing can also help identify any implementation barriers associated with data collection and can estimate costs or burdens associated with data collection and data analysis. Beta testing can add to the feasibility evidence obtained during alpha testing, For example, there may be new implementation challenges identified among the sites participating in beta testing that were not detectable during alpha testing when you're just using your in-house or convenience sample of test information. Beta testing can also evaluate the feasibility of measure score stratification, so you can see if there's adequate volume in subgroups such that statistical differences are identifiable. Next slide, please. Lastly, we'll talk about the usability and use criterion. So to address this evaluation criterion, alpha testing may include qualitative testing, so focus groups or interviews with patients, with measured entities, or with technical expert panels about the usability of the measure. On the other hand, beta testing may identify unintended consequences, including susceptibility to inaccuracies and errors. And beta testing may include qualitative testing on refined or final specifications. So hopefully with this walkthrough of alpha and beta testing, you have a sense of the key differences between the two types of testing in terms of scope, timing, and purpose, and how they address measure evaluation criteria. But to further distinguish the terms, I'm going to just provide an example of testing activities that may occur under alpha testing and then under beta testing. So next slide, please. An activity that might be undertaken during alpha testing is on this slide. So the measure developer has drafted specifications based on the results of an environmental scan, plus technical expert input, and uses those specifications to extract data from their in-house health system database. What might we do with this data pull during alpha testing? So there's a couple of things you might do. You can ensure that required elements are available in the format needed for measure calculation. For example, can you actually have a patient refusal exclusion in an ECQM if these data are only captured in an unstructured note? You might also use this data pull to assess the frequency of exclusions and other critical elements. So, for example, you may decide that an exclusion that occurs with very low frequency is not worth including in the measure. And we'll talk a little bit about those sorts of trade-offs you might think about as you're developing your measure in just a few minutes. Next slide, please. So here we have an example of what some beta testing activities might look like. In beta testing, rather than working with your in-house data set, you might enlist multiple test sites that use different EHR systems to extract data, compare those data against manual chart abstraction, and to calculate measure scores. So you could calculate patient encounter level reliability. You can conduct additional feasibility tests at these new sites that will help identify any implementation barriers and burdens. You can identify differences in calculated measure scores between sites and within subgroups. And towards the end of this presentation, my colleague Mujahid Khan is going to talk about some strategies for collaboration with measure testing sites that can support successful beta testing. But for now, we're actually going to move on to another one of our testing challenges, which is validity and feasibility trade-offs. Next slide, please. So measure developers are faced with lots of decisions informed by measure testing that have implications for how the measure is going to stack up against the different evaluation criteria. One trade-off that you may have considered before concerns validity and reliability, whereby efforts to make a measure more reliable may weaken validity and vice versa. But today we're going to talk about a different trade-off, and that is the trade-offs that might occur between validity and feasibility. Next slide, please. So decisions about validity and feasibility are often encountered during alpha testing while you are drafting your specifications. As a reminder, validity answers the question, are you measuring what you want to measure? Whereas feasibility answers the questions, are the data readily available and can the measure be implemented? Many times, more often than any of us would like, the perfect, the ideal, most clinically valid data element cannot be feasibly and reliably obtained. For example, the information you want to include may reside in a scanned document or in an unstructured field. Next slide, please. So the trade-off you're confronted with is illustrated by the seesaw here. It's whether to select a data element that is more clinically appropriate but more difficult to access, or a data element that may be less clinically appropriate or precise but easier to access, feasible to access. Next slide, please. So the question is, how do you handle that situation? One important principle of measure development that I'd like to encourage, and that's in this blue box on the right side of the screen, is that transparency is important in measure development. We encourage you to be transparent and explicit in your explanations for how your measure might differ from your ideal scenario. You want to document your compromises and justifications for your decisions. This is critical because it informs measure adopters and implementers about the why behind the decisions you arrived at. And perhaps even more importantly, it can actually help build the evidence base for making changes to code systems, EHRs, or other data sources that actually enhance future feasibility. So that said, we would encourage measure developers to develop the most clinically valid measure possible with the understanding that changes in code systems and technologies may very well increase feasibility over time. One example of such an evolution we've seen over the past year is that LOINC codes now distinguish between germline and somatic testing of BRCA gene mutations, which actually now makes possible the measurement of adherence to testing guidelines, which was previously infeasible. So again, the key takeaway here is to be really clear and transparent about any validity and feasibility trade-offs that come up during measure testing and any other trade-offs from the ideal measure that you may need to make. Next slide, please. So we're going to switch gears again and talk about some newer terminology that we've seen cause a bit of confusion. And this is the term patient/person or encounter data and how that differs from patient-reported data. Next slide, please. So patient/person or encounter level testing incorporates what was formerly referred to as data element level testing. So patient, person, or encounter level data refers to discrete information captured about a person or encounter, and that could include things like disease states, medical history, or healthcare services performed. These data can be obtained from health records, from claims, or administrative data, or any number of other data sources. One thing that we really want to hammer home is that patient in person or encounter level data is not the same as patient reported data. And that's just sort of underscored in that blue box on the right side of your screen. Next slide, please. So why should measure developers care about the difference in these terms? Well, one important reason is that completed patient/person encounter level testing of each critical data element when appropriate is one aspect of CMS's definition of a fully developed measure. So this type of testing could include comparing electronic versus a manual extract of the data element. This type of testing is not the same as testing a patient-reported data collection tool or survey. So the key takeaway here is that patient encounter level data refers to discrete kernels of information that comprise the measure. It does not mean that the information was collected directly from the patient. So hopefully that helps clarify the difference between those two terms. And I think we can move on to the next slide. So there's one other consideration we wanted to raise to this group when we think about testing the data elements that comprise a measure. And that is that there are some data element resources that can actually help with measure testing and measure development. Next slide, please. There are two repositories that you can access online for data elements. The first is the CMS Data Element Library. That is this centralized resource for CMS assessment instrument data elements and their associated IT standards. And we have the link up here on the screen. And there's also a repository of data elements that are used in ECQMs, and that is located on the ECQI Resource Center. Again, we have the link here up on the screen. Next slide, please. So what are the benefits of referencing or sourcing existing elements from these repositories? A couple of benefits listed on the slide. So if other measures are using the same critical data elements that you intend to use in your measure, you can cite prior evidence to support your assertions of validity and reliability. So it has the opportunity to kind of fast track your tests of scientific acceptability. Secondly, checking the DEL and the data element repository also supports efforts to align and harmonize measures where possible. So you're really ensuring that measures that capture the same concept are measuring that concept the same way. And that helps to reduce reporting burden and improves comparability of information. Next slide, please. Moving right along to the next topic in our assortment today. You may have seen some recent peer-reviewed or popular press reports that the COVID-19 pandemic has brought about a bit of a backslide in patient safety. So patient safety events that have become more common during and since the pandemic, more so than we would like. For the most part, these remain relatively rare events, but they are so impactful and consequential when they do occur that they are worth measuring. So again, these are things that don't happen very often, but when they do happen, the consequences are worth tracking. Next slide, please. So one example of a fairly low frequency event that we have on this slide on the right is wound infection that may occur subsequent to a surgical lung biopsy. So the low frequency or rarity of this event poses particular challenges with regard to testing. Specifically, it can make it difficult to obtain acceptable measure reliability thresholds for measured entities. We'll talk about some potential solutions to this challenge on the next slides, but before we do that, I just want to note that it's important that the solution that you end up with for your particular measure should really take into account the strengths and weaknesses of each approach, as well as the ultimate intended use of your measure. Next slide. So one option to consider is partial pooling or borrowing strength, which is a technique to strengthen data in one of two ways. You can pool your data across longer timeframes to capture greater event frequency. So in that case, you're essentially lengthening the measurement period. Another option is to pool data together of providers with similar structural characteristics, and then use data-driven weights to apply to the data based on the amount of measurement error. So those are sort of two different ways of partial pooling or borrowing strength. Next slide, please. In addition to those two more statistical methods, there are some approaches to dealing with low frequency events that involve modifying measure specifications. For example, you may consider measuring the time between events rather than a count of the events. So that would mean creation of a continuous variable measure. Or you can create a measure without a denominator. For example, you could create a rate measure, such as the number of infections per month. Another option relating to specification is to broaden the measure focus. So you increase the frequency of the measured event by developing a composite of similar events. So going back to our initial lung biopsy example, instead of measuring just wound infections, you would include any or all complications of lung biopsies in a composite measure. So again, the solution that you arrive at when you're confronting a low frequency or rare event should really depend on the intended use of the measure, but these are just a few options for you to consider. So we've talked about a number of different types of challenges confronted by measure developers during measure testing. And we're going to now move on to talking about another major component of measure testing, and that is the engagement of testing sites. So I'll now turn it over to Mujahid Khan for a deeper dive into that topic. Over to you, Mujahid.
Thank you, Meredith. I wanted to discuss now the benefits that measure developers may gain from collaborating with other testing sites. Next slide. As measure developers, you might already be engaged with other testing sites for alpha and beta testing data. However, formalized collaboration can help ensure that there is efficiency and promptness in the testing process along with a more rigorous data quality output. In addition, developers can discuss shared learnings about feasibility, identification of best practices, and identify a network of clinical experts. Most importantly, collaborating testing sites are viewed as true partners in the process of measure testing and are vital to the measure's success. Next slide. Some collaboration strategies include holding a kickoff meeting to formally inform sites about their measure intent, ultimate implementation, and use goals of the measure. Consider hosting an on-site, in-person meeting or online event that gives participants a chance to fully engage in understanding the value of the measure. For one particular measure, we hosted an annual in-person reception that recognizes sites for their efforts and encourages the momentum to keep going. Set up trainings that use developed materials such as abstraction manuals, templates, and specification details to assist sites staff in data collection. This can even be a step-by-step toolkit that guides each disciplinary team member in their role to ensure successful measure testing. And schedule periodic check-in meetings to keep communication open with sites and address any data quality challenges or questions that arise. A virtual 30-minute coffee break or pulse check once a month is a great way to allow sites to bring up any pressing issues or share progress regularly. These check-ins became particularly notable during the pandemic when sites were navigating COVID-19 protocols while aiming to maintain some form of testing. Next slide. Additionally, think about reporting back. It is important to report results of interim and final analytic findings back to the site. This helps sites understand their progress, and they may want to use this information to learn about quality improvement results at their facility. In addition, sites may sometimes use their site-specific data to garner more resources such as technological enhancements or staff, as well as obtain leadership buy-in. And stay in touch. Keep sites informed about the status of the measure and important milestones, especially big news surrounding the measures and the consideration list submission or the consensus-based entity review. This allows sites to feel invested in the measure's success. Next slide. Think about establishing a learning collaborative for your measure. Instead of working independently with each site during the testing process, gather a group of sites to host regular meetings and engagement to discuss similar challenges and learn from one another. This ensures a consistent message is being communicated to all site participants. The learning collaborative will also create a role for a measure champion, or someone who champions the measure at each site. This individual could be a QA specialist or a clinician who will also be the primary point of contact to the collaborative. The measure champion will work cross-functionally with staff to understand gaps in measure testing and report back to the collaborative. One major benefit of a collaborative is the pool of resources gathered from participating sites. Rather than reinventing the wheel for each resource at each site, participant sites can easily share resources, tools, and knowledge via an online platform where data collection is already set up. Finally, consider publishing a regular newsletter or e-blast to inform about site-specific news, wins, and opportunities to network. Ultimately, it is critical to realize that participant sites are true partners in the collaborative, and measure developers should make every effort to value their time, commitment, and dedication. And with that, I will pass it back over to JJ.
Awesome. Thank you so much, Mujahid. Great points about the Learning Collaborative. All right, everyone. So we want to hear from you. What has been your experience collaborating with testing sites? A poll is going to pop up on your screen. It just popped up on mine. So if you could take a minute to submit your response while we transition into our Q&A session. Next slide. All right. Yes, if you haven't already, thank you guys or thank you, all of you, for answering these questions. I can see the live results right now. So thank you for taking the time and submitting questions during today's session. If you hadn't had the chance to, please go ahead and submit your questions using the Q&A feature at the bottom of your screen. Also, please note any resources that we shared in the chat today are also available in this presentation on the resources and links slide. So with that, let's jump into some questions. All right, Meredith, you mentioned saturation as the context of alpha testing. Would you mind elaborating on what data saturation means?
Hi, yeah, thanks. Good question. So saturation is actually a term from qualitative research, which is not my specific background, but basically data saturation is a state where you reach enough data to draw your conclusion. So you've collected enough data to draw your conclusion. When you've reached saturation, additional data is kind of just repetitive and not adding new insights. So this ties into alpha testing because maybe you've conducted interviews and added key informants to ask them about their views on the appropriateness of an exclusion. And maybe after a handful of these interviews, you start to hear the same opinions asserted over and over again. When that happens, you've likely reached saturation, where you've heard kind of the range of thought and identified the universe of variation in opinion. And so any additional further conversations wouldn't really add any new insights. And as we've talked about with some of these other challenges, that's an important, conceptual thing to understand, but there's also the practical consideration as well, right? So paying attention to when you've reached saturation can be useful because it helps you preserve resources. It essentially gives you your stopping point in qualitative research. Hopefully that helped.
Yeah, that was great, Meredith. Thank you. Mujahid, you mentioned a measure champion. Is that someone you should identify from the beginning when you are first engaging with the site?
Yeah, that's a great question. Ideally, it is best to have identified this individual early on when you're engaging with the testing site. And that's because you want to make sure that the champion has a stake in the measure testing and the process. And then ultimately what they will do is they will get the buy-in from the rest of the site and the facility. So it's their job to kind of champion the measure at that site. So it's best to have this individual identified early.
Thanks, Mujahid. And also just want to note, thanks to those who answered the poll, it looks like a lot of you are comfortable with this idea of collaboration. Of our respondents, 51% have participated in kickoff meetings, periodic check-in meetings, and trainings. So those are some of our primary forms of collaboration. All right. Question, Meredith, can you provide an example of validity testing for process measures, especially those measuring adherence to validated published guidelines by ancillary providers, such as radiologists or pathologists?
Yeah, so I think a deep dive into different types of validity testing is probably a great topic for a future info session. So I can't really give you a super comprehensive answer right now. But one sort of test that measure developers will often look to do is to take their measure and see how it compares to similar measures. So if you have a measure that's assessing adherence to a guideline, maybe there's another measure that tests adherence to a similar or related guideline, and you would expect those two measures to sort of correlate highly. So they would both be measuring similar constructs, and so you would expect them to be, a facility that rates high on one would rate high on the other. There may be other measures where you expect them to be performing in the opposite direction. So in cases like that, I think the key recommendation is to form a clear hypothesis of how you expect the measure to relate to other measures that you're using to test validity against, and then test that hypothesis. So you state an expectation on how you expect the measure to perform, and then you interpret your results in light of that hypothesis. So again, I think a great topic for a future info session.
Thanks, Meredith. Are there any resources you can point me to learn more about the partial pooling and borrowing strength that you mentioned earlier?
Yes, a great question. Those are some statistical techniques, to help address the challenge of a low frequency or rare event. But NQF actually produced a nice report on low case volume in rural providers that provides information on partial pooling or borrowing strength. So it's a little tricky because low case volume, which is in the title of the report, is different from the challenge of a rare event. So a low case volume affects the denominator, whereas a low frequency event is more of a numerator problem. But that said, the primary focus is on low case volume in this report, but it does also contain information on rare events as well. So I recommend checking it out for that reason. And I think we can put another link in the chat to that resource if we haven't already.
I'm sure Jake is on the case. And Meredith, while we have you, could you discuss a little bit about how do you know if a measure is topped out?
Yes. So that's a good question. And there are a couple of things to look for when you're deciding or determining if a measure is topped out. So generally speaking, for a process measure, that's considered topped out if the median performance on the measure is 95% or higher. So that is suggesting that most of the measured entities are doing pretty well. They're on the high end of the distribution. So there's not much opportunity for improvement there. If you're talking about other types of measures, so aside from process measures, there are a couple of other things to consider. So there's two actual criteria there. You want to see first if the truncated coefficient of variation is less than 0.10, and if the 75th and 90th percentiles are statistically indistinguishable. So you want to see if they're within two standard errors of one another. And just for anyone who's interested, you can calculate that truncated coefficient of variation by removing the lower and upper fifth percentiles, and then you divide the standard deviation by the mean of that truncated distribution. So there's a couple of specific statistical criteria that will determine if your measure is topped out.
Super helpful. And Meredith, I like how you're just diving in there, not afraid to get into the technical. That's great. So, and I'm not, maybe you or Mujahid could maybe talk or speak to this, but we had a question about data element reliability testing. So would you say data element testing is inherent if reliability testing is completed?
Would you mind repeating that question? I want to make sure I didn't.
Sure. Question was, would you say data element testing is inherent if reliability testing is completed?
So if reliability testing at the data element level is completed, then reliability testing is completed. But you can also test reliability at the measured entity level. And so the key here is that you're testing at that data element, or as we say now, patient/encounter level testing is the key. So testing reliability at the measured entity level is not sufficient alone. You have to get to that data element level as well.
And hopefully that got at the question. And also, anyone, if you have questions and we aren't able to get to them, all within scope questions, we will work to address following the session today. Meredith, there was some clarifying question about the topping out discussion we were just having. Does this include performance among and between populations? So in other words, could a measure be topped out in one population and not be topped out among others?
That's a good point. I think that's fair that a measure could be topped out for one population and then there's still room for improvement in another population as well. So I think it's all about how the measure is reported. If you're not reporting it by subgroups, you're looking at that overall topped out status. But if you're looking at different stratifications, then you can look at topped out among those stratifications.
Great, thank you, Meredith. Let's see. Trying to see, we have a few other questions rolling in. Looking at what we have. Sorry, everybody. When performing a gap analysis, are you to include everyone who has ineligible encounters or only those practices choosing to report on the measure? I'm not sure if that might be for you, Meredith.
So I think when you're conducting a gap analysis, you're really trying to understand if there's a quality issue that can be improved upon, right? So I would cast a broad net in that case. So look beyond just, who will be reporting on the measure, and cast a broad net. And I think that's, what the literature will do as well. So you're looking for support that there is a quality issue that's occurring that can be improved upon through measurement.
All right, we also had a question regarding electronic clinical quality measures. Wondering who they could talk to specifically regarding ECQMs and measure testing. And we are going to refer you to the quality payment program. We can include some information about how to contact them directly to provide you with some more resources specific to ECQMs. So you can look for that in the chat. All right, I think that covers most of our questions. And like I said, if we weren't able to get to your question today, all in-scope questions we will look at and follow up with following today's information session. So Jake, if we could move to the next slide. Here are the resources and links, as I mentioned earlier. Things that were shared in the chat in support of today's presentation are included here just to keep them handy. Next slide. Thank you again for all your great questions and involvement in today's session. We would like to invite you to join us again this June for a public webinar on the CMS National Quality Strategy, which is a long-term initiative that promotes quality outcomes, safety, equity, and accessibility for all. There are 2 opportunities to attend, so please register for whichever one fits best into your schedule. Next slide. As always, please visit the CMS MMS Hub to stay up to date on all the latest MMS news, events, quality measurement resources. And thank you again for your participation in today's session. Great questions, poll participation, and we look forward to seeing you all in June. Thanks, everyone.